Hello and welcome to our Parliamentary Friends of Palliative Care event for 2021. My name is Camilla Rowland and I'm the CEO of Palliative Care Australia. And I'm delighted to have you join us today to reflect on the past, present and future of palliative care in Australia. In this, our 30th anniversary year, Palliative Care Australia has acknowledged and celebrated the amazing dedication of all those working and volunteering in palliative care in Australia across the past 30 years. It's important to mark this milestone, and we also appreciate that there's still much to be done to ensure palliative care is recognised and properly funded in the years ahead. So today we reflect on the history of palliative care and look to the future with an eye to the challenges and opportunities that lie ahead. Over the past few weeks, our team have spent some time with former PCA board directors, capturing their reflections and insights into the development of palliative care and the impact of PCA's work over the last 30 years. We have also collated your questions in the lead up to this event, and we hope to get as many of those in today's session as possible. Thanks to you, our audience, for sending these in. Before I begin, I'd like to acknowledge that I'm hosting today's event from the lands of the Ngunnawal people. I also acknowledge the traditional custodians of the various lands on which our guests are based. Although you may be joining us from right across Australia, PCA's national office is located in Canberra on the land of the Ngunnawal people. So, as we go forward, we would like to, first of all, acknowledge and welcome Senator Katrina Bilyk to officially open this event. Hopefully, one day soon, we'll be able to join our co-conveners of this Parliamentary Friends of Palliative Care group back in person at Parliament House. But for now, welcome, Senator.
Thank you, Camilla. Good afternoon. My name is Katrina Bilyk. I'm a Senator for Tasmania, and along with my colleague, Nola Marino, the Federal Member for Forest, we are the co-conveners of the Parliamentary Friends of Palliative Care. Nola's joining today's panel and I look forward to hearing from all of our speakers. Let me welcome everyone to this special virtual event. We trust that the next hour or so will give us an opportunity to reflect on the past 30 years of palliative care in Australia and look at insights to lead the future of palliative care in our country. As has been highlighted, especially with the continuing effects of COVID, death and dying is universal. Everyone's life has been or will be touched by the death of a loved one, and many of us here today have known family and or friends who have received palliative care. Today's event will capture the reflections of former PCA board directors on the development of palliative care and the impact of PCA's work over the last 30 years. And our panel session will discuss the future of palliative care ahead of the upcoming federal election, with an eye to the challenges and opportunities that lie ahead. I'd like to extend a very warm welcome to our guest speakers, Professor Meera Agar, Professor David Currow, Nola Marino, and of course our MC for today's event, Palliative Care Australia CEO Camilla Rowland. Just before I hand back to you, Camilla, can I congratulate Palliative Care Australia on 30 years of brilliant work in Australia. Thank you for joining us today. Back to you, Camilla.
Thank you, Katrina. Let me now introduce you to our guest speakers. With me today is Professor Meera Agar. Meera is the Chair of Palliative Care Australia and a practicing palliative care medicine physician in southwest Sydney. Meera leads an impressive clinical research portfolio at the University of Technology, Sydney, including clinical trials and health service evaluation. Meera's research and teaching has won numerous awards, including an Australian Learning and Teaching Council citation, an Australian Award for University Teaching, and the European Association for Palliative Care Early Learning Career Researcher Award. Welcome, Meera.
Hi, Camilla.
Also joining us is Professor David Currow, the new Deputy Vice-Chancellor at University of Wollongong, Health and Sustainable Futures. Previously, David was a Professor of Palliative Medicine at Impact, improving palliative aged care and chronic care through clinical research and translation at University of Technology, Sydney. He is an Associate Director, Research for the Wolfson Institute, University of Hull, and a former president of Palliative Care Australia and the Clinical Oncology Society of Australia. Welcome, David. Congratulations on your new appointment, and thank you for taking the time to be with us today and for contributing to our anniversary celebrations.
Thanks for the opportunity, Camilla.
Finally, the Honourable Nola Marino MP. Nola is one of our parliamentary co-conveners for the Friends of the Palliative Care Group. Elected as the Federal Member for Forest, WA, in November 2007, Nola was appointed Deputy Government Whip in September 2013. In September 2015, Nola became the first female to be appointed to the position of Chief Government Whip. Welcome, Nola.
Hello, how are you all?
Thank you, Nola. Welcome to our panel members, and thank you for being with us today. So, over the past 40 to 50 years, palliative care services in Australia have transitioned from an informal network of enthusiasts to a strong network that exists between specialist palliative care providers, primary generalists, primary specialists, and support care providers, and of course the community. Up until and following Palliative Care Australia's establishment, there have been many significant milestones in the palliative care sector in Australia. Many of the key historical events and milestones were reported in the 2013 Cancer Forum Journal article, Evolution of Palliative Care on Australia, 1973 to 2013, written by David and Emeritus Professor Jane Phillips. So David, can you provide us with some insights about the transition in Australia from the limited hospice services which existed in the 70s and prior to the evolution of palliative care services? And how has it become a specialised branch of medicine since then?
So as we look around the world, lots of things were happening in the 1970s and 80s. We had tremendous leadership from Italy, from Canada, from England, and indeed, in Australia, we saw that leadership coming from oncology services. It's really impressive to reflect on some of those early leaders who saw the need and really wanted to take the process of providing excellent palliative care into their clinical practice. And so in the late 70s, we had leaders, particularly in Victoria, looking at how to integrate. And when we look internationally, that's exactly what Balfour Mount wanted to do as he returned from spending time in England. Rather than creating freestanding services, how do we ensure that wherever people encounter health services, they are able to access high-quality palliative care? The then Anti-Cancer Council of Victoria commissioned a report in the early 1980s, which was incredibly prescient. It suggested that if we're really going to reach the populations of need, then we need to integrate this at every level of the health service, as your introduction has indicated, in primary care and in tertiary care, in inpatient, outpatient, and community settings. And the really successful services around the country have done exactly that in the intervening years. With regard to it being a specialist service, Australia was at the forefront. And what we saw was that the Royal Australasian College of Physicians formed a subspecialist training committee in 1988. That really put us way ahead of the rest of the world. That training program was in place, and we've seen a steady stream of those clinicians coming into the workforce since then. That was paralleled in nursing and sadly has not been paralleled as strongly in allied health. In medicine, it was complemented in 2000 with the formation of the chapter of palliative medicine, and more recently with the offering of a clinical diploma for people who wanted a special interest in this area, but where this was not going to be their exclusive clinical practice.
Thanks, David. Did the transition parallel the development of subspecialist oncology services?
So oncology services were developing in the mid to late 1970s, and we forget that it is that recent. And so palliative care wasn't far behind, but that legacy of people coming through oncology services has been maintained, and so the majority of people referred to palliative care services are still with a cancer diagnosis. I think one of the challenges for the future, about which we may talk in a little while, is how we ensure people with non-cancer life-limiting illnesses can fully access the breadth of services that are available today.
Thanks, David. And look, we're aware that the commissioning of the Ross Webster report, Palliative Care for Cancer Patients in 1983, by the Anti-Cancer Council of Victoria was a defining moment for the early evolution of palliative care in Australia. What was so significant about the Ross Webster report from 1983?
This was a watershed moment, and the Webster report really took us from isolated individual opportunities to provide care for people with life-limiting illnesses to saying we need a systematic approach that is integrated right across health. That integration is still occurring today. One would have to be honest and say that particularly for some diagnoses outside of cancer and neurodegenerative diseases, access to palliative care is still far too low. But the Webster report said government needs to invest in this, community needs to invest in this. This has to be a whole of community approach. And that set the framework for lots of thinking in the years ahead. At that stage, we had many hospices across the country, but they were freestanding, often not connected to the rest of the health service, often not connected to people in the community who wanted to spend as much time as possible in the community as they still do today.
Thanks, David. And you mentioned about hospices, and that's a good segue into our next question for Meera. Palliative Care Australia was formerly known as the Australian Association for Hospice and Palliative Care and was established in 1991. What was the significance of establishing a national peak body for palliative care? And can you share with us the challenges around 1990?
So I think the formation of a national peak body was really critical for the progress of palliative care in Australia, and I think looking back it was really reflective of the vision of several leaders at the time to consider the future needs of the Australian population, really recognising that the provision of palliative care in Australia was going to have its unique challenges due to the nature of the way our health system is funded, our health system and our geography. And really, I think it provided opportunity to bring those pioneering leaders together, develop interest in the health sector more broadly, to share ideas, problem solve, and reflect on how to apply to the Australian context this momentum, this incredible momentum and sharing of ideas that was being seen internationally. And I think looking back now, these foundational steps have really paved the way for Australia to have policy and strategic direction both at the jurisdictional and national level, and we are really fortunate to be able to continue to build on that today. And as David said, it was through that leadership that we actually positioned Australia to have that first subspecialty training in palliative medicine, and I think bringing those jigsaw pieces together really allowed us to do that. And the challenges, I think, Dame Cicely Saunders in a paper in 2001 reflected in the Journal of the Royal Society of Medicine, a paper titled The Evolution of Palliative Care. And they spoke about our need to respond not only to physical symptoms, but the psychosocial and spiritual needs of people with life-limiting illness. The need to build a sufficient workforce who had the skills and passion to work in this field, and to develop the evidence base. And though we've come a long way working on those three areas, I think those would have been the challenges faced at that time and continue to be the areas that we still need focus today. I think it's also important to really recognise that early leadership in Australia for those who provided exceptional services for those dying from HIV and AIDS, and I think that's another contribution to palliative care globally that Australia can be really proud of.
Thanks, Meera. So turning to you, Nola, Learning of the establishment of the National Peak Body for Palliative Care, can you talk to us about the importance of the Parliamentary Friends groups, particularly ours, and what benefits they can bring for advocating for quality palliative care?
Oh, thanks, Camilla. Look, I think I'm very pleased to be a co-convener, and I see for practical purposes how no matter who you are in the Australian Parliament, it gives an opportunity for Palliative Care Australia and all of those engaged in this sector a place to actually meet with all sides of politics together, usually in one spot. And with COVID, that hasn't been possible. But that really gives an opportunity to raise the profile of palliative care and the importance of it across the whole Parliament at any given time, which is what this type of gathering today is also about. So it also presents what are the current issues facing palliative care. And as we've heard already, how palliative care has evolved, so then the needs change, and that's the responsive nature of the Parliamentary Friendship Group, and the fact that we then have access to either ministers or shadow ministers in this space as well. And of course you've seen shadow ministers across the board as well as our ministers come along to our gatherings, and that gives direct access to the ministers in this space. But the awareness raising, keeping it on the front foot with all of us in the federal parliament all of the time, that's a really important avenue for that to happen.
Thank you, Nola. And when did you first get involved in the Parliamentary Friends group, and what was your motivation?
Look, initially I was very close to Senator Judith Adams, who was at that time in the Parliament the co-convener. And Senator Adams developed life-threatening cancer and passed away, as we know, in 2012. And she was very keen to have someone who was as committed to palliative care to take on the role. And I'd been engaged since basically getting into politics through Judith, and then was really, really honoured to step into her role, given the journey that she'd had and the importance that palliative care had played in her journey, but also what I'd had to deal with in life, being a mature-aged MP, had to deal with the practicalities of parents going through palliative care and other relations, including my own sister, and through the years, even right down to recently, a great nephew who was 5 this year, who needed specialist help and support. So it's an enduring commitment, and also through personal experience through all levels, whether it's in-home palliative care and support, through to hospital, through to an aged care facility, and all in between. So that's the nature of it, and I think that person-centred approach is so important and ongoing. I think that's the approach we will all be taking to this.
Thank you, Nola. And look, really what we're saying is that the Parliamentary Friends groups, as well as the government in general, are incredibly important in support of the movement of palliative care. You know, we've seen over many years a number of initiatives that have been absolutely critical to policy and practice and the evidence base, including, you know, advanced care planning, including undergraduate qualifications and embedding palliative care and undergraduate qualifications in clinical work, as well as the National Palliative Care Standards. And without the government support and funding for those initiatives, palliative care wouldn't necessarily be that level of quality care that we see today. So moving on, David, we know that Professor Ian Maddox became Professor of Palliative Care at Flinders University. He was the world's first university chair in his discipline. He introduced pioneering postgraduate courses in palliative care with distance study and helped facilitate the development of palliative care throughout Australia. Can you explore how training was first implemented and how it's been developed over the years?
So I think when we talk about academic courses here, Camilla, we're really looking at the established workforce, and the Flinders program has now been mirrored by many programs across Australia. I think the real benefits of the Flinders program were its reach into Southeast Asia. That was critical, and that was further extended to low and middle income countries, 15 years later, and many of the people who have been part of that program are now leaders in their own jurisdictions, which is really fantastic to see. When we think about this, again, the emphasis has largely been on nursing and medicine. There are many people who've graduated with an allied health background, but again, we haven't invested enough in the positions that they need to fill in order to really have person-centred care as we move forward. That program, as we've seen in other postgraduate programs, is really critical for the established workforce. And I'm excited to see that as we look around the world, the number of those offerings continues to increase.
That's a very good point, Dave. And then moving on to you, Meera, speaking of education and research, how has Australia been a leader in palliative care research and a driver for change in this space?
And I think we can be proud that Australia has really made a significant contribution both in the volume of research but also its quality. And really a lot of the work that comes from our region underpins the contemporary evidence we have for our practice and our service models. And that's in a broad range of research areas, in health services, in clinical trials, but also in understanding the lived experience and the impact of care for people and their carers. And key to this over time has been the recognition of the need for targeted investment by government. I think the Australian research community has set a very high bar for itself, that the research that they have undertaken has been competitive in funding against non-palliative care peers. The researchers have invested in the capacity building of the next generation of researchers, and so we have people equipped with the skills to take on our current clinical questions and build that research going forward. And really a concerted effort across the country in terms of knowledge translation and reducing the evidence practice gap. And I think all of that has come together to really enhance the services and the outcomes for people with palliative care needs across the country.
Very interesting, Meera. And I guess that also leads me to the next question is, how has the definition and meaning of palliative care changed from its initial formation?
I think I would say that the key evolution has been much more a focus on need rather than prognosis. And regardless of diagnosis or location of care. And I think David touched on that in his earlier comments, that we've really moved from palliative care being an institution or a place to something driven by need and really integrated with our systems and our communities. And it's now, I think, very clearly established that those needs occur very early in a diagnosis, and we need timely access to this need. And it's often called early palliative care, but I think the dialogue around this is that it's actually timely care based on need, regardless of where that is in someone's illness journey. And I think we've also realised that outcomes are much broader than just symptom control. Improving function and independence and rehabilitative aspects of care are much more recognised, and we're now having discussions around what palliative care can contribute to survivorship and what that means. And so I think the conversation continues, but we have, I think, touch points in many parts of the healthcare system, and also during people's illness, where we can really fundamentally make a difference to outcomes.
Thanks, Meera, and thanks all of you for your great insight into the beginnings of palliative care in Australia. As I mentioned earlier, over the last few weeks, PCA has had the pleasure of meeting with former and current PCA chairs, presidents and directors, including Meera and David, to get their insights on the challenges, achievements and advancements that palliative care has seen in Australia.
My time at PCA was at the very beginning of the formative years. Perhaps I could take it back to 1988, the appointment of the first chair in palliative care, and Ian Maddox, who became the first president of the association. He set about doing university courses and wanted to have a national meeting, the first national palliative care conference, and that was held in Adelaide in 1990. There were some international speakers and people came from all around Australia to be a part of it. And that was an opportunity for Ian to begin some discussions about setting up a national association, a national body. And that was the very beginnings of Palliative Care Australia, where these very grassroots organisations in each state were pulled together at this national conference and said, let's have a national body. Ian led the way there. He had the vision and the charisma to get the various states. And as we know in Australia, there can be state rivalries. But there was a good sense of cooperation to get this up and running.
I think there are a number of challenges. They included maintaining a productive relationship with government, but in particular there were challenges around strengthening governance for Palliative Care Australia, and this was primarily done through changes to the Constitution and a strengthening and greater clarification of the role of the board under that new Constitution. I think also critically maintaining strong collaborative relationships with the state and territory entities was an ongoing challenge.
There's the challenge of working in a federation. And during the time that I was at Palliative Care Australia, there was a revamp of the governance structure so that a true board of directors was brought together for the first time. That was an important step for the organisation. And together with that, the ability to strategically plan nationally in ways that value added that could not be achieved at a state or territory level alone.
I think one of the biggest challenges we faced as a board was navigating the voluntary assisted dying laws that were being introduced at the time, having that balance or that dance between supportive messages, but also not having a side or coming down in favour or proposing one particular direction. It was quite a difficult navigation, but I think we came out of it the other end with a very strong message and a very strong supportive document to enable people moving forward to behave in a compassionate manner, but also that was in line with their own values and the values of the organisations they were working in. And we acknowledge that. There was diversity, still is, and that's fine, but we all need to work within that supportive framework. So I think that was a great achievement, but it took a while to get there and many iterations, many discussions.
There was the challenge of euthanasia. It's a topic that came up with almost every media interview, no matter what topic we wanted to take to the media, and that continues 20 years later.
The other thing that I remember at the time was developing a statement around voluntary assisted dying, and the position that Palliative Care Australia took was that of studied neutrality, staying out of the for or against positions, but being able to balance the needs of people at the end of their life, whatever those needs be.
I think it's been the introduction of voluntary assisted dying that's been a challenge for those in the palliative care sector, and of course PCA. While voluntary assisted dying doesn't naturally align with the philosophy of palliative care, it certainly has provided a platform to highlight the current and chronic underfunding of the system, the potential consequences of inequitable access to palliative care, and importantly, the benefits that quality palliative care offers to those with a life-limiting illness and their families.
what stands out for me is the development of what I would see as being a more public health approach to palliative care, focusing on enabling people to live well in the final stages of their lives. We developed the slogan, dying well, and that dying is everyone's business, and that caught on quite a lot and has been used in many places over subsequent years.
Research, a decent body of research, a very high profile on all realms of healthcare, getting government recognition and support. Oh dear, it's just come in 30 years. It's extraordinary how much it's gone from just even being recognised as a discipline. And I felt that we're very much the marginalised sector of healthcare. It was kind of the soft touch, the soft area of medicine and nursing and general practice. So to be recognised now with a very solid body of research, very respectable profile of research, postgraduate PhD level research happening as well. It's up there with all the other disciplines, and I think that's the greatest achievement.
Biggest achievement, I think, whilst I was on the board of Palliative Care Australia, was the work that Palliative Care Australia had done with other international groups around advocacy that brought about the World Health Assembly inaugural resolution on the integration of palliative care into all health systems nationally. And I think that was a huge piece of advocacy work that was really important for the field, not only within Australia, but also internationally. And I think it led well to the development of the National Palliative Care Strategy within Australia. So I think a magnificent achievement.
I feel the biggest achievement for Palliative Care Australia is making it to 30 years. I have the utmost respect for the resilience of this organisation, and credit to all of those within the workforce, whether it be volunteers, whether it be advocates or clinical specialists. It takes a lot of courage to continue doing the work that they do, and I think I've been very proud and overwhelmed to see how consistently they fight and advocate for the right to access palliative care. To make it to 30 years when they are constantly fighting for a seat at the table is an incredible achievement, and overlooking all that they've done in terms of reform over the past 3 decades and going into the 4th decade is astounding. So I think more broadly looking at all of what they've achieved, I think that to me has been something to certainly look back on and be incredibly proud of.
One of the great achievements of PCA in recent times has been the formation of the Yarning Circle, really showing that commitment to our Reconciliation Action Plan and making sure that we're engaging with First Nations people in the best possible way, which is to really encourage and support and make it possible for them to lead so we can learn from them and make sure they're getting access to the right kind of palliative care when and where they need it.
I think the biggest achievement is that we've been able to bring together both the clinical, social and moral imperative for access to high quality palliative care with the economic argument. And being able to argue that it makes economic sense and that investing in palliative care is really what is needed to make a robust and secure health system for the future that's going to serve Australia well. The second achievement is really our renewed and ongoing commitment to the palliative care needs of Indigenous Australians.
So I think one of the biggest advancements in palliative care over the last 30 years would be the fact that it now is recognised as a core component of health services and starting to be also recognised as a core component of aged care services. I think that palliative care has come from historically from being a service that was offered to few in our community, and it demonstrated its value in providing and improving the quality of life of people who are dying in their families. But I think what the biggest advancement is now that our community has come to much better understand how this is a service that everyone should expect and deserves. And it's a part of what our policymakers, our decision makers need to resource and fund adequately.
So in that time, what I've seen with Palliative Care Australia's endeavours and advocates like me, advocates at a state level, I've seen a significant increase in funding and resourcing and education, not only of practitioners, but also of the general population. And Palliative Care Australia did a tremendous amount to make the conversation about palliative care, what it is, how to get it, and how it can nourish and hold people. They did a wonderful public education job with that. And so people now know the term and they can understand a little bit. You know, when I use it in my work now, I find people know what I'm saying. As soon as I say palliative care, there is a response. Whereas when I first started, you'd say palliative care and people would look puzzled. So there's been a huge movement in public and professional and sector awareness about palliative care.
I think that things have certainly advanced since I was a student many moons ago with respect to the recognition of the role of allied health, including physios in palliative care. And now we have a dedicated allied health and palliative care group in Australia, as well as a dedicated cancer, lymphedema and palliative care physiotherapy group. And having had no formal palliative care teaching in my undergraduate degree or formal support to help me, in working around death and dying, I'm excited to see the work that PCA is currently doing around the development of generalist palliative care and around education. And I think we really need to promote that work and ensure that, no medical or nursing or allied health graduate who lands themselves in a hospital ward is ill-equipped to have basic conversations about death and dying or to be able to support their own self-care in that.
What a wonderful insight into experiences and developments over the years. Thank you to everyone who's been involved. It was evident from listening to past and present board directors that voluntary assisted dying laws were and still are a challenge. As we expected, some questions have come in regarding VAD from members of the sector. Deborah Pryor, PCA former board director, asks, what guidelines will PCA and palliative care providers recommend for working with voluntary assisted dying? Meera, perhaps you can speak to this.
Yeah, so Palliative Care Australia released the guiding principles for those providing care to people living with a life-limiting illness, with the purpose being twofold. One, that we were really wanting to ensure that appropriate care is provided to people with a life-limiting illness, but also to maintain appropriate, respectful and cooperative relationships between healthcare professionals. And I recommend those listening today to have a look at these principles in more detail. But just to give you an overview around the key areas, these principles importantly talk about the need for respectful relationships with colleagues, the support for professionals to work within their own professional and ethical values, whether they're working within specialist palliative care or more broadly in the healthcare system. And I think we also place a really high value on effective communication, ensuring that people with a life-limiting illness who are choosing to explore voluntary assisted dying are not abandoned. And that health professionals really need to have a strong awareness about their learning needs in terms of conversations about end-of-life care, symptom management, self-care and grief and bereavement, and take responsibility to maintain contemporary understanding and scope of practice in these areas.
Thanks, Meera. Now to a question from Doreen, who is a volunteer in Canberra.
Considering the changing laws for VAD, how will Palliative Care Australia ensure that there are sufficient provisions to address the psychosocial and spiritual needs of palliative care patients and also to support mental health wellness of carers and nursing staff in their challenging roles.
It's long been the case that we need ongoing investment to ensure an adequately resourced and appropriately trained healthcare workforce who are familiar with the broader aspects of palliative care provision, including the clinical areas, but also the legal, ethical, and broader psychological aspects of providing this care. And I think particularly important is the development of advanced communication skills to be able to actively listen, engage in respectful dialogue with people about their end-of-life preferences. The palliative care workforce is highly competent in supporting people by enabling these exploration of complex social, spiritual, cultural, psychological, emotional and physical aspects of their care preferences. And the Palliative Care Australia is going to continue to advocate for embedded systems that provide best practice training and support to really facilitate wellbeing in a proactive way, both for palliative care practitioners, volunteers and others who work with people with palliative care needs. And similarly, much more is needed for the health system as a whole. We know that people with advanced illness are being cared for in our communities, in our aged care facilities, in our intensive care units and through our emergency departments. And these high-level skills are going to be needed in all of these areas so people can actually respond to people's psychosocial and spiritual needs.
Thanks, Meera. And Doreen has another question.
What steps will be taken by Palliative Care Australia to offset the effects of increased demand for more access to euthanasia?
The PCA's focus is really on trying to address the significant unmet need for high quality palliative care in Australia. And the forecast is that this need is going to significantly increase in the years ahead. And so what we need is investment at the national, state and territory levels to ensure that systems and people are able to provide quality palliative care where and when it is needed. And palliative care is explicitly recognised under the human right for health. And every Australian living with a life-threatening illness should have equitable access to quality needs-based palliative care at any point in their illness journey.
Thanks, Meera. We are still facing issues today, especially around VAD, but also the perception of palliative care. Although there have been advancements in this area, as Professor Patsy Yates noted in the video, that historically palliative care was a service that was offered to a few in the community, but now it is increasingly seen as a service that everyone should expect and everyone deserves. Nola, as someone who has first-hand experiences with palliative care, do you believe community perceptions have changed regarding the meaning of palliative care over the years?
Well, from my experience, Camilla, not enough yet, I don't think. I think there's still a perception in many people that palliative care is simply for those last days or even weeks of life, where in many instances, as Palliative Care Australia often says, they'd like to get people, 10 years perhaps ahead if they've got chronic and continuing pain associated with a life-threatening condition, so that they can help them live well during their time. But I think there's still a perception in many that palliative care is about the very end of life, not the journey to that point. So I do think there is more that we need to do in that space. And I think part of that as well, I do the odd advanced care planning session myself. I think that's also a real key with what PCA does, is around the need for really good advanced care plans. No matter what age you are, it's important that they're in place to reflect your needs, again, that person-centred approach, no matter where your life takes you.
Thanks, Nola. David, we have a question now from Palliative Care Nurses Australia. PCNA have asked, how can we unleash the potential for health professionals, and notably nurses, to work to their full potential, empowering and advocating for optimal palliative care for all patients in all settings?
Palliative care nurses are optimally placed to advocate for patients. And the opportunity to do that in primary care and specialist care is second to none. It's also important that palliative care nurses are empowered to work at top of scope so that they can demonstrate to their colleagues what really good nursing looks like. I think of the emerging areas of primary care where primary care nurses have a national body. We need to work closely alongside them. We need to work alongside all of the discipline-specific nursing roles that are developing across our communities and ensure that each of those health professionals has the key skills that are required for a palliative approach. And as we've looked at curriculum development nationally, some core competencies for every health professional, nursing, allied health, medicine, really need to be at the forefront of that process. And so for palliative care nurses in Australia, there is an opportunity for advocacy on a day-to-day basis, modelling great palliative care, advocating particularly to their colleagues about the importance of a palliative approach when people have chronic progressive illnesses. And in that setting, we can really make some significant changes in the years ahead.
Thanks, David. Nola, coming to you, with your experience in government, how strong a role can politicians have in supporting and advocating for national peaks, specifically palliative care?
Well, I think we've already seen some of the outcomes of those, and even through the parliamentary friendship groups as well. And there's no doubt that the messages that are delivered through Palliative Care Australia are taken by those members of Parliament, both through Palliative Care Australia gatherings and the Parliamentary Friendship Group, but also on an individual basis. And that can have a significant impact, particularly if you have lived experience yourself. And often it's not until you have someone in your family that is very close to you, or very close friends or family that have a need for palliative care, that you actually understand the process and the system and those engaged in it. So I think, yes, certainly MPs can have an impact in dealing with the ongoing issues that will arise, not just now, but as we move through this, as we've already heard this morning.
Thank you, Nola. And why do you think access to quality palliative care is still impacted by someone's postcode? What's the solution to improving care in rural and regional locations?
Look, I deal with rural and remote communities, even in my role as the Assistant Minister. And sometimes it can be a great challenge to get those services actually available in very remote communities. And it can be a challenge to get health professionals into those locations with the skills that have been referred to today. So I think making sure that those skills are then supported and enhanced right across the sector, so irrespective of where you live and work. I know there are some very, very committed health professionals, and even the local GPs, no matter where they are really keen to make sure that the people who rely on them for health care and advice get the best possible services and support that they need. So I think it's at all levels, and there's more and ongoing work that we are doing and will continue to do in this space.
Thanks, Nola. David, Beth Bennett is a Community Ambassador for Advanced Care Planning Australia, and she asks, what are the developments in home-based palliative care that have occurred recently? Is work being done to ensure people in rural and metropolitan residential aged care facilities are offered palliative care support?
So lots of really good things are happening in community palliative care. I see much greater integration between general nursing services and specialist palliative care services. Continued wonderful engagement from general practitioners, as Nola has just alluded to, and that is critical. The areas of caregiver support are also pivotal to care in the community, and we mustn't forget that the biggest single predictor of being able to stay at home for as long as possible is someone who is a resident carer under the same roof. I think there's much more that we can do into the future in ensuring that we are providing better support for caregivers. In terms of residential aged care facilities, which is the other part of the question, again, there is unfortunately something of a postcode lottery around the country as to whether the local service sees a residential aged care facility as part of its responsibility or not. From my point of view, at a policy level, this is the person's home, and we need to support that person with the full range of services that are available to everyone else in the community. It is as simple as that.
Thanks, David. Currently, palliative care is not appropriately recognised and funded in aged care. Why is this? And what needs to change, Meera?
So I think it's significant that the Royal Commission into Aged Care Quality and Safety recognised the fundamental importance of palliative care in the delivery of quality aged care. And PCA's Palliate plan provides 8 points which really provide us constructive solutions to really tell us how to improve this in the future. And the first point is that a person-centred approach will allow us to focus on needs and not just the last hours to days of life for a resident in aged care or someone being cared for in the community by aged care services. That we need the aged care quality standards to be inclusive of palliative care. We need palliative care training for every health and aged care worker. We need to improve our data about older Australians receiving aged care with palliative care needs. We need investment to improve the provision of palliative care into aged care, whether that be in residential aged care or community-based aged care. And we need to ensure our models are adaptable for equity access across Australia, and so this should be regardless of geography or population. We need to continue to support older Australians to understand what good palliative care means, and palliative care in aged care really needs to be a priority for all of our governments.
And Meera, has the Royal Commission into Aged Care assisted in advocating more for palliative care?
Yeah, I think the report really was critical in really naming the central need for palliative care as a core component of palliative care, aged care provision. And that was across training, workforce and the direct clinical needs of people receiving aged care.
Thanks, Meera. David, regarding aged care, a clinical question has come in from Maria O'Donnell, who is a chief clinical pharmacist of a large service provider to aged care. And she asks why clinical pharmacists are not involved in palliative care case conferences.
In the case conferences that I've organised and in the health service research that I've done, pharmacists are absolutely key. Polypharmacy is a major issue, and we need pharmacists there with their expertise, particularly to reflect on medications that may not be of benefit now or in the future for that particular person in the context of their life and their illness. It's critical that pharmacists are seen as partners in the process of providing excellent palliative care wherever that person is, in the community, in residential aged care facilities, or in inpatient settings. And so I'm a keen advocate for pharmacists being very active members and hearing that voice whenever we have the opportunity for a case conference.
So David, looking forward, what are the opportunities for palliative care sector in the future?
As we think about palliative care, it's timely to reflect on the journey that we've had to bring us to here. We came from many backgrounds, and if you look at the original practitioners in palliative care, they came from general medicine, from oncology, from pain medicine, from anaesthetics, from psychiatry. I think we need to be bringing those people in during their careers into palliative care, from nursing, from medicine. I've already said we need to invest far more in allied health. And Meera clearly stated one of the major issues that patients tell us is, I want to be independent for as long as possible. That requires really great physiotherapy and occupational therapy consultations early, getting households ready for that in order to better maintain that physical independence. None of us here today are looking forward to the day that we have to reach out and ask for help, knowing that having reached out, we're going to have to continue to reach out for that help. And so beyond symptom control, we really need to do much more to optimize people's physical function for as long as possible. In the psychosocial aspects of care, we need to think about the long-term outcomes for caregivers as well. We've touched on psychosocial issues, but I would like to see as one of the measures of successful palliative care in the coming 3 decades that the health and well-being of caregivers long-term, long after they've finished the role, will be improved because they've had access to palliative care. And finally, as we look to the future, personalised medicine is taking off in so many other disciplines. In palliative care, we're way behind. We need to know from day one, is this particular intervention more likely to work for this person? And for that, we need to look at large studies. We need to continue our research. We need to look at the genetic studies that are just starting in palliative care, so that in 10 years' time, when someone comes in and says, here's my complete genome, we'll be able to say, actually, for your type of nausea, we know that this has a greater chance of working than simply chance itself. That's a big shift, and I will be parochial here, Camilla. We have the best cooperative clinical trials group in the world, the most productive. It was supported by the federal government for 10 years, and that support finished in 2016. That group is defining better quality care, and we need to invest in that again, because through those sort of investments, we're able to personalise care. We're able to better identify some of the harms that we've caused, that we've attributed to disease progression when in fact it's been our prescribing. Those are really key issues for the future of palliative care.
Thank you, David. Further to David's comments, Nola, where do you think advocacy for palliative care should go?
Oh, look, I just think already we've got very good advocates in Palliative Care Australia as well, and people like David himself. But I think it's a continuous process in advocacy for palliative care. And as we evolve, and the services that David talked about need to be rolled out, into our very rural and remote and regional areas, that our advocacy piece will be ongoing right across all of the disciplines here without any question.
Thanks, Nola. So Meera, what are some of the investments and initiatives needed over the next 5 years to ensure all Australians have access to high quality palliative care when and where they need it?
Thanks, Camilla. And I think the first thing is we do need increased funding for direct delivery of palliative care, whether that be in home-based hospital or residential aged care settings. We need an agreement and some performance indicators in terms of how the Commonwealth and states and territory governments can work together and effectively leverage the resources that are put into palliative care to really optimise the outcomes achieved from those initiatives. I think integration between primary, other specialist and specialist palliative care is going to be really critical. And we're going to need a national palliative care workforce strategy against the projected population needs, and that needs to take into account geography and diversity. With continued investment to improve data, that will help us then continue to inform our policy and our service delivery and planning. And we need to continue dedicated funding for palliative care and end-of-life care research so that we can make sure we have the contemporary evidence to meet the challenges that our population needs are going to put to us for the future.
Thank you, Meera. And turning to Aboriginal and Torres Strait Islander people, this is a group that's currently underserved when it comes to palliative care services. So Meera, what do you think are some of PCA's short and medium plans to see greater access to culturally safe and trauma-informed palliative care services for Aboriginal and Torres Strait Islander people?
So what we would like to see is investment in the development and delivery of culturally appropriate care models for palliative care, but also for aged care for Aboriginal and Torres Strait Islander people, led by Aboriginal and Torres Strait Islander people. And a national palliative care action plan in this field would really help bring that goal together. We need to also build our workforce capacity in culturally safe care and ensure that we make sure that our workforce planning more broadly really specifically thinks about the needs of Aboriginal and Torres Strait Islander people and the Indigenous workforce who wish to contribute to providing this care. No, I think navigation and access to aged care will also be really critical. And Aboriginal and Torres Strait Islander controlled organisations should be really supported to contribute to meeting this need.
Thank you, Meera. David, how do we educate all health professionals about their role in delivering palliative care to their patients and consumers?
We get them young. Look, at the end of the day, it needs to be in every curriculum, and the four core components that were defined through the palliative care curriculum development need to be in every nursing, allied health and medical curriculum in the country. We've also got a workforce out there for whom this was not part of their undergraduate or immediate postgraduate training. And although we have wonderful things like the Palliative Experience program, at the end of the day, what we really need to do is ensure that every palliative care practitioner sees the education of colleagues as part of their work. It can't fall to a few, it can't fall just to academic institutions, and as every practitioner should see research and professional development as part of their work program, so they should see education. We really have a huge task. We then add to that the challenge that Australia continues and will, through its policies, continue to import large numbers of health practitioners to meet our basic needs. We have to ensure that those people are aware of contemporary palliative care practice and work alongside them to model best practice palliative care. As our evidence base continues to rapidly improve, and it is improving, getting that evidence into practice, and Meera has referred to translation already, is a key challenge in any clinical discipline, but I fear it's more so in palliative care for some fairly cogent reasons. At the end of the day, we're still in evolution, and we need to ensure in that process of evolution that we are training the literacy, the evidence literacy of the current palliative care workforce in order to broaden the education available to every health professional in Australia.
Thank you, David. We now have a question for Meera from Vicky Barry at Young Dementia Network Western Australia, who asks, given that dementia is a terminal illness with no known cure, how do we close the gap of inequity of access to specialist palliative care for people living with dementia and assure them the best death possible?
So I'd point Vicky to a special issue of Palliative Medicine in 2018, and Julian Hughes and colleagues reflect on the area of dementia and palliative care, and I think provide us a real insight into the focus of our future efforts. So firstly, they raise the need that we need to continue to recognise dementia as a terminal condition, as Vicky rightly points out, and the relevance of palliative care. And this is both in the community at large, but also amongst healthcare professionals. Secondly, I think we need to recognise that people with dementia and their caregivers do have specific palliative care needs, and know that the premise that it can be considered as no different from conditions that others die from doesn't always hold true, and we need to build some specific capability around providing palliative care for people living with dementia. And then in that case, we're going to need a model of care which accommodates the needs of people with dementia. And this is going to need a composite of methods, training, strong multidisciplinary teamwork and coordination of services. And we have real opportunity to optimise the strengths of specialist dementia care, specialist palliative care, and the broader services who provide excellent services for people living with dementia regardless of setting, and actually harness and work together to improve outcomes for this group of people.
Thanks, Meera. And another question for you. This one's from Mark Waters, CEO of Palliative Care South Australia. And he asks,
can you please forecast which groups we, as a strong network, should prioritise for better access to palliative care?
I'd like to think, Mark, one way to think about this question is that if we ensured that every initiative we put in place thought about who would miss out, who might miss out, and tailored our systems to meet this gap in the first place, then we're going to start building systems that don't leave people behind. But I think in light of this question, we do know that we do have some catching up to do. And I think the Royal Commission to aged care sets us an imperative to prioritise access for those receiving community and residential aged care. Importantly, this group of people are likely to have multi-morbidity and dementia. We also have an important commitment to Aboriginal and Torres Strait Islander people. And we really need to get the model of care right for access in rural and remote communities, as we've discussed already during this conversation, and make sure that this is adequately resourced. And there are some other diverse needs groups which will also require our attention really to make sure that we have equitable access across our population settings and geography.
Thanks, Meera. David, we have a question for you from Ilse Hampton. Ilse is a PCA Board Director and CEO at Meaningful Ageing Australia.
Supporting someone at end of life and their loved ones requires much more than physical symptom management. My question is this: what would it take for every person who is accessing community or residential aged care to be able to also access holistic palliative care support to enable them to take a peaceful final breath?
So there's no doubt that physical symptom control is critical. When you ask patients, their caregivers, the health professionals who provide care for them, physical symptom control is the number one issue that they raise. But it is not an end in itself. It is a means to an end, and it's a means to an end so that people can spend meaningful time with family, so that people can finish off legacy issues that are important to them in the context of their lives. Good physical symptom control is imperative as people make peace with those around them and the world in which they live. And so to do that, again, we're back to what are the needs of this individual? How do we assess those needs comprehensively and then bring in the resources that support them? It isn't a one-size-fits-all cookie-cutter approach. It really is saying we need to understand this person in the context of their life, their lived experience, and indeed their lived experience of others around them dying, in order to ensure that we're going to provide the sort of care that Ilse has outlined in her question. In doing that, we're back to needs-based assessment, and it doesn't matter what diagnosis. It doesn't matter about the prognosis. This person now has a life-limiting illness, and we as a community, not as health professionals alone, but we as a community are going to respond in a way that will support that person until their last breath.
Nola, what would you like to add to David's response on what it would take politically to make this shift?
Look, I think David is spot on in the sense that people want to be able to live their last period of life the way that they want to and be supported in that. And I think there's a broad understanding even now we see more focus on people who do choose, and we see a greater proportion of people. I think I heard stats some time ago that 70 or 75% of people would actually like to die at home. but a very small percentage actually do. So I think how we facilitate that through very good palliative care really does matter, and we need to be able to support that and support people's wishes in that space where we can as well. So I think there is a great focus on the end of life care process, but I think respecting the wishes of individuals and how we deliver that is is the challenge that we face. And I think David is spot on about how and where people choose to spend their last days, their last hours, their last time, and with whom, and how they want to do that in a way that makes them most comfortable and able to spend those last hours critically the way that they choose to do so.
Thank you, Nola. Meera, coming to the present, what has the COVID-19 pandemic shown us about the value of palliative care?
So I think the COVID pandemic has really shone a light on the immense contribution of palliative care for our community. I think the first thing is that ability to manage severe symptoms, whether that be shortness of breath or other physical symptoms, and the distress associated is such a critical role that we play, and played a significant role in caring for people who had COVID-19 and who were dying. And really other capacity is to provide personal support for people who are seriously ill. I think the other aspect is that we actually are in the business of prevention and reduction of clinical problems, particularly in our work in the community and in residential aged care. We're thinking about the problems that may occur and putting plans in place to prevent those happening in the first place. And that's so essential in keeping people away from hospital and avoiding unnecessary emergency department presentations. And I think that role also was really critical as we responded to the needs of people who, for a range of reasons, needed the care really to be provided outside the hospital setting. And the other thing I think we really contributed and continue to contribute is really innovative solutions to personal connection, despite the extenuating circumstances that the pandemic brought. And so that value of preparedness and systems that can provide care in the person's preferred place, communication skills influence the care we offer, and that we need to work, regardless of the discipline within those fields that they came from, really working together. Those who needed healthcare for conditions that they already were living with also were met. And I think the community really listened. I think that there's also the poignant absence of some really important things, visitors and human connection, and the volunteers that work with this terribly, and I think really illustrate how important they are to the provision of palliative care.
Thanks, Meera. And continuing on with that COVID-19 impact, Nola, about care at the end of life.
Oh, look, I think we've seen some really profound impacts on families and individuals through COVID. Those that couldn't get to visit people they love very much where they were in Australia, and the profound impact that's had on them. And I think it's certainly brought to the fore, as Meera has said, how important good palliative care is, and the challenges that so many have faced during COVID, and often the closure that so many people need when they lose someone that they love very much, that effectively they have not been able to receive during COVID. And so that we've seen that during the COVID period, and I think Meera's right. The community has stepped up. And what we see is that beautiful caring that's come, and I've seen a lot of that in my own part of the world, where people have taken care of others because there was a need and because no one else was able to do so. And I think that's a real measure of who we are as Australians, that we actually do help each other when the need is there. And in these circumstances, that's what we've seen. But there is no doubt that there has been so many people who've not been able to meet and see their families at this end of life period, and that will stay with them for, you know, probably the rest of their own lives. And I think that's been one of the real issues that we've seen with COVID.
Thanks, Nola. Vicky Barry at Young Dementia Network has another question. She asks, we are living longer, but arguably we are dying longer. We have entered what she calls the slow death movement and have created a death-phobic society with very little exposure to and understanding of the natural dying process. Meera, how do we change that?
I think the COVID-19 pandemic has helped the Australian community really understand the importance of us speaking about illness and speaking about death, and beginning to understand what our preferences and values are around serious illness. And I think we need to continue these conversations. We need to think about how we can improve the experiences that people have and interactions that people have with people who do have a serious illness, whether that be through programs in schools, through how we train our undergraduates in health, but also in other areas of work. The people who are working in our banks and in our councils and our other places where people who do have a serious illness do interact on a regular basis. And I think we took a really multi-pronged approach and allowed people to have lived experience and to not be frightened of those experiences, and supporting each other, including younger people in that. I think we will progress and learn from the things that I think as communities we did understand not so long ago, and tap back into those experiences to drive better conversations.
Thanks, Meera. David, what areas of research?
Really tapping in palliative care will tell us much more. And we need to be able to sit down and talk to patients and their families about the like. I think we have been slow in providing that. Another area is in health service research. And in health services research, we've got great opportunity to refine the models that we have, be it for rural or remote, for some of the sprawling suburbs in the outer suburbs of our major metropolitan areas, all of which provide unique challenges and therefore unique opportunities for research to better inform what we do. I've already alluded to the fact that most of us will probably have a genome-wide sequence that we'll take to our health practitioners within our lifetime. In palliative care, we have not been nearly active enough in looking at some of those predictors, again, for harms and benefits for a particular clinical course. We've got artificial intelligence here and machine learning. I'm only aware of a couple of papers that have even touched on that in palliative care. So there's great opportunity for us to tap into new research methodologies that will answer questions more quickly, more effectively, and more accurately. So it's an exciting time. And as we think about the populations that we haven't served, we have so much to learn in palliative care for people with end-stage renal disease, end-stage respiratory disease, end-stage cardiac disease, end-stage hepatic disease. And, you know, we've seen this transition over the last 20 years of bridge to therapy becoming actually a destination therapy itself in several of those end-stage organ failure settings. How do we take that forward in the palliative care setting in the years ahead? It's an exciting time. The biggest challenge is not going to be doing the research, it's going to be managing to ensure that that's translated into practice and into policy as quickly and effectively as possible.
Thanks, David. Now, finally, a question for our whole panel. Where do you hope palliative care will be in the next 30 years? We might start with Nola.
Look, I hope that person-centred approach that we've discussed and we've heard much about it today, where people actually get to the point where they've done their advanced care plans, irrespective of their age, because I think that's really, really important. And that you're very clear in what you want, where you want to be, what medications you're choosing, what's available to you, and that you do make plans in the full knowledge of what's out there, and we keep improving what we've got to offer. And I want more people to be able to have the choice that of their own choice as to what those final days are, and that they can be comfortable and have a person-centred approach to that. And that's where I hope we will be. And I hope, though, that more people understand palliative care far better than they do now, but they do choose to actually draw up their own end-of-life care plan, that they've got people around them who will make sure that their wishes are respected and that we're able to deliver on those.
Thank you, Nola. And coming to you, David.
Well, clearly, the first thing to say is I don't want them to be providing care for me in that next 30 years. I've booked my hospice bed a little further down the track, so that's really important. Look, in the next 30 years, I want to ensure that every Australian, no matter where they live, can have equitable access to the quality outcomes that palliative care can deliver. This is not a process issue. It's not saying let's provide the same for every single person, because every person's needs are different. The support networks that we need to complement are different. And so irrespective of who they are or where they are across the community, we're able to provide that person-centred, needs-based care. And that's a massive challenge given our geography, given the diversity in our communities, and our need to respond to each individual. But we can do it. And finally, I want to see that we provide much better support for caregivers in asking them, are they willing, and separately, are they able to take on the role? And then looking at the education and support we provide them while in the role, and in the transition away from the role of providing that care. I really want a metric that says we are providing better long-term health and well-being for caregivers because they had access to high-quality palliative care.
Thanks, David. And finally to you, Meera, about the next 30 years.
I totally agree with both Nola and David in terms of their vision, and I'm an optimist, so I think we can achieve all of those things within the next 30 years. I think to add to that, I think we need palliative care to be responsive and integrated, with really the health system, clinicians and the community working together in partnership. And I think we know how to do that, and I think we can achieve that if we work together. And I think Australian research would have directly contributed to better ways to achieve those quality outcomes that David refers to.
Thanks, Meera, and thank you all for your positive final points today. We have reached the end of our time for today, but on behalf of Palliative Care Australia, a big thank you to Meera, David and Nola for taking the time to join us today and for such an informative and reflective discussion. Not only have you helped us highlight some of the key challenges and achievements in palliative care over the years, but you have focused on the important opportunities for palliative care in Australia in the future. It's an exciting time looking forward to where palliative care could and should be, and improving access to high quality palliative care for all palliative care patients, when and where they need it. Your continuous support and involvement in PCA, especially in commemorating 30 years of Palliative Care Australia, is greatly appreciated. I'd like to acknowledge the amazing dedication across the sector, including those working, volunteering and passionately advocating for quality palliative care over the last 30 years. I'd also like to acknowledge and thank all the past and present directors, chairs and presidents for their significant contribution to palliative care in Australia. Thank you to everyone who has joined us today and contributed to the success of this, our final Parliamentary Friends of Palliative Care event for 2021. Enjoy your evening.